Talking about implant-specific occlusal issues, we said that we are going to define some specific features with implants, and some of these features are related with what we can call software problems, and software is related with the problems of function, proprioception versus osseoperception, the way motor control is working on implants, what parafunctions are doing to implants, and the other issue is the hardware issue. So it is what is related with morphology, so how a prosthesis is made, what is happening with normal load and with overload on our implants, and most of all what is happening to the bone, what is happening to the bone implant area. So we said hardware is everything related to morphology, while software is everything related to function. And when we talk about implants, one of the most important things we have to consider is that we do have something called cortical neuroplasticity, and this cortical neuroplasticity is very important, especially in large rehabilitations, because it means that the oral environment can adapt to a restoration, and this cortical neuroplasticity is very important, because without cortical neuroplasticity it would be really difficult to place, for example, a large rehabilitation in a dentulous patient and to have this large rehabilitation accepted by the patient and to have it functioning and working properly. We have good quality papers investigating what is happening with sensibility of osseointegrated implants and with jaw motor inputs coming from osseointegrated oral implants. And the most important thing about software on implants is that when we consider a patient with a full dentition and we compare this patient with another patient completely edentulous, what we know is that there is a huge difference in terms of proprioception. And when we consider an implant patient, we realize that there is not so much difference if the patient has one single implant and all natural dentition, and the difference is getting bigger and bigger when the patient has much more implants and some restored teeth, if the patient has an upper arch all on restored teeth and a lower arch on implants, if the patient has implants in one arch and removable in the other arch, or if the patient has full arch rehabilitation on implants, upper and lower. In the last case, the patient is much more similar to an edentulous patient because he does not have any periodontal mechanoreceptor. So in these patients, what is working is something called osseoperception. And osseoperception is a term which was proposed by Bronnemark to recognize the oral kinesthetic perceptual abilities in the absence of a functional periodontal mechanoreceptive input. So osseoperception is very important because we have patient functioning also when there are no information coming from periodontal mechanoreceptors. So talking about software with implants, so function with implants, there are probably big differences in larger implant supported rehabilitations compared to conventional prosthesis or to natural dentitions, while in smaller treatments, single crowns or fixed partial dentures occluding with natural teeth, the amount of missing data is probably not so relevant. Our system can manage to work with some less information, but it's working. When we are dealing with hardware of our implant restorations, we have of course some problems, as we have problems in conventional prosthodontics with hardware. And the problems are, for example, screw loosening, screw fracture, sometimes even implant fracture, for example as in this cantilever prosthesis. But we do have problems with hardware also on conventional prosthesis, different problems, but yet we have this kind of problems. In the past there was attempts to make some emulation of the way natural teeth are working, for example with these devices to soften the contact, and these attempts were made with a good intention, but they all end up in failures. When we deal with hardware, we have a clinical condition which is some way a test of our prosthodontic structures, and this clinical condition is bruxism. If we try to answer a question, is bruxism a mechanical risk factor for implant-supported prosthesis, we can look at some existing literature. We have some studies where patients treated with implants have been described, and the presence of bruxism has been considered, and the conclusions of most of these studies are that bruxism is a mechanical risk factor for the prosthesis. So there are much more complications in bruxism at the level of the prosthesis on implant. At the same time, if we try to answer the question, is bruxism a biological risk factor for osseointegration, so not for the structure of the prosthesis, but for the bone implant contact area, and we look at literature, we have several other papers, and most of these papers give us the conclusion that bruxism is not a risk factor for osseointegration, so it's not affecting what is at the level of the bone implant contact. And these are most of these studies. Some say no, some say that it's uncertain, but most of the answer is no, it's not a biological risk factor. So the most important area is what is happening at the bone level, and as we have seen, most of clinical studies tend to say that nothing is happening at bone level, but there are some controversies. And to try to look into these controversies, we can look at what experimental animal studies are telling us. There are a lot of experimental animal studies looking at what is happening at the bone level, and we can group them into two different groups. One group found a relation between bone loss and load level, while the other group did not find a relation between bone loss and load level. When we describe these papers, we have some in the first group, the positive relation between bone loss and load level, and these are 6 studies. Some of these studies are very popular. For example, there is a paper by Isidore in 1996. And usually when someone is telling at a meeting that the occlusion is affecting the osseointegration, he is going to talk about Isidore studies. Actually, these studies was done with a clinical condition which was quite particular, and the experimental condition was not so realistic. There are, of course, some papers, for example, the Miata paper, describing an effect of occlusion on bone loss, and this is a very good quality paper with an experimental condition which is much more similar to a clinical condition. Then of course this is done in monkey mandible, so we are still looking at animal model, not clinical evidence. When we look at the group of studies with no relation between bone loss and load level, actually this is a much larger group. Here we have 5 studies, here we have 5 more studies, and here we have 7 more studies. And some of these studies are very popular. For example, Heights Mayfield 2004, it's a study about excessive occlusal height in dog mandibles, and it's saying no, there is no relation between excessive occlusal load and bone loss. And as in the case of the Isidore paper, every time someone is going to say that there is no relationship between occlusion and bone loss, he's going to cite this paper because it's very strong in its conclusions. Then, of course, there is the issue of what is happening with overload when there is peri-implant microbial infection, because we have to deal with peri-implant microbial infection. And also in this topic we have different conclusions. We have a paper by Hurzler saying that there is no effect of overload with or without inflammation. We have a paper by Gottfriedsen saying no marginal bone loss due to overload, no effect over inflamed peri-implant bone. But we do have two other papers. Miata 2002, overload can lead to marginal bone loss without inflammation, and it can enhance the progression of marginal bone loss when inflammation is present. And we have one more paper by Kozlowski in 2007, and this is saying that overload aggravated the plaque-induced bone resorption when peri-implant inflammation was present. So we have basically two papers saying that there is no effect of overload when there is peri-implant microbial infection, and two papers saying that there is an effect of overload when there is peri-implant microbial infection. Of course, these papers are different because the experimental model are different, the way the load is transmitted to the implant is different, and so there are a lot of differences, and it's not possible to put them together and to have some common conclusions. And a good conclusion probably comes from the paper of Miata in 2002. We can say that the contact between implants and epithelial or connective tissue is fragile, and inflammation and occlusion need to be controlled more prudently than in the case of natural teeth, and this is something that we all agree. So we go back to our outline. We have looking at some literature, we have been talking a little bit about changes in the way occlusion is considered in dentistry in recent years, and we have described some specific issues on implants, the software problems, the way the central nervous system is managing our implants, the hardware issues, what is happening on the prosthodontic structure, and what is happening also at the bone implant level. So the way occlusal load or overload can affect or not osseointegration, and the role of load of occlusal load in relation to peri-implant microbial infection. And now, of course, we want some conclusions from what we have seen. And as you all realize, there are several controversies in literature, but we need some conclusion in clinical practice. So how do we manage occlusion on implants? We have a case with a crown on a tooth and a crown on an implant, one on one side, one on the other side. And how is the occlusion on these two different crowns? Actually, it is managed exactly the same way. The occlusion is made according to the available space, is made according to the morphology of the near teeth, and it's adjusted exactly the same way. Is there clearance on these single implants? It's not touching? Absolutely no, it's touching the same way as the crown on the natural tooth is touching. I did not want to have clearance on that implant when I put it, but even if I did it, I don't know if it's going to stay in this clearance for a long time. This is another patient. I treated him with an implant several years ago. Then he went abroad to study, and he stayed with a resin provisional for more than 4 years. And when he came back, there was a lot of wear on this provisional. And if we look at the antagonist tooth, it has erupted a lot. So can light contact be light forever in a single implant prosthesis? Actually, I do not think so. So this is the reason why I'm not looking for clearance on single implants. So how do I manage occlusion if I have implants and restorations on natural teeth? Absolutely the same way. The morphology is absolutely the same. The kind of contact is checked in the same way. I do not want to have lateral gliding contacts on the crowns on the implants? Do I want to have them on the teeth? No, I do not want. What I do not want to have is sliding contacts on restorations, because we know from literature that sliding contact under masticatory force is highly deleterious to the layers of our restorations. So we are doing the same things on our natural teeth as we are doing on our implants. How do we manage occlusion in a case like this, where there are two missing lateral incisors? An orthodontic treatment has been done, two implants has been placed. We had some veneers on the central which were really worn, and we have two crowns on implants, and these crowns are adjusted as if they were crowns of natural teeth. They are not touching in excursions, but of course this would have been the same thing also if they were crowns on teeth. And how do we manage occlusion in larger rehabilitations, like in this case when we have implants? Actually, we manage the occlusion in larger rehabilitation exactly the same way that we manage occlusion in larger rehabilitation in conventional prosthodontic treatments. And we have to rebuild everything of the occlusion of these patients. So we have to work for a long time with provisionals. We have to test the way our changes in vertical dimensions are working. We have to rebuild guidance, disclusion. We have to rebuild everything, and we are doing that, choosing the proper instruments, working with systems with occlusal schemes we have been working for years in conventional restoration on teeth. So when we talk about occlusion and implants and teeth are obviously different, and there are several reasons why we have to check carefully occlusion on implants. You cannot leave the occlusion on your implants not carefully checked. But aren't we doing the same on restored natural teeth? Aren't we checking the occlusion on our crowns on teeth? I don't think that we are having less care on restored teeth. So what I would say is that, considering the available literature, considering what we can do in clinical practice, we are dealing in the same way on implants and on restored teeth with our occlusal schemes. I would like to thank you for listening to this presentation. This is my mail address, this is my Facebook profile, this is my Twitter account. You can feel free to contact me for any question you could have. Thank you very much.